So as I said before the break, I think Dr. Takala has set up a scene for us, given us a sense of the complexity and all of the different ways that we can not only keep people at work, get them back to work, but also prevent injury. And so taking that one step further, we're going to have a look at some of the issues here in Canada, some of the numbers, again to set the scene. And then at the end of this morning, we're going to start looking at, well, what can we do about it? And so to start off that process, what I'm going to like to do now is to introduce our next speaker, who's Dr. Peter Smith. And he's a scientist at the Institute for Work and Health here in Toronto, and the Canadian Institute's Health Research Chair in Gender, Work and Health. So he's Associate Professor in the Dalla Lana School of Public Health at U of T, and Peter has extensive experience conducting work-related research in work-related injury and consequences in large population-based surveys. So key interests are gender, sex differences in relationship, work, injury, and the labour market experiences of newcomers, older workers, younger workers, and other vulnerable labour force subgroups. So I'd like to introduce Peter, and thank you very much for coming and helping us spell out some of the issues. Peter.
Good morning. Thank you for the introduction, Richard, and the invitation to come and speak today. So the presentation we have today is in two parts. I'm going to give the first half, which will be about 20 minutes, and Ivan Steenstra, a colleague of mine at the Institute for Work and Health, will give the second half of the presentation, which will also hopefully be about 20 minutes. Focused around age, labour market participation, limitations of work and work injuries. For those of you who don't know, we both work at the Institute for Work and Health, which is a non-profit research organisation in Toronto. Most of our funding comes from the Ministry of Labour, very similar to CRE-MSD. The work I'll be presenting today has been sponsored by a variety of organisations, so you can see on this slide, including WorkSafe BC and the Canadian Institutes for Health Research. So I'd like to start off by talking about 6 common statements that we often hear about older workers. First one is the number of older workers in the labour market is increasing. Older workers leave the labour market or have restrictions in activity at work because they have more chronic conditions. Older workers have an increased risk of work injury. Because they have more chronic conditions, that's the main reason older workers take longer to return to work after a work injury. Older workers need different types of interventions to help them stay at work or to return to work after a work injury, and particularly in relation to musculoskeletal conditions, they need different types of work interventions. And what we'd like to do today is comment on each of these statements that we hear and give you some research evidence about whether they're true, they're partly true, or not true at all. So here's a snapshot of the Canadian labour force, and it is ageing. This graph shows the percentage of the labour market who's 50 to 64 years of age and 65 plus, and you can see that it's increased from about 17% in 1990 to over 30% in 2013. And that equates to just under 2 million workers 50 to 64 years of age were working in 1990, and now almost 5 million workers 50 to 64 years of age are in the labour market. And among the 65 plus year age group, that's more than tripled in size, going from about just under 200,000 workers in 1990 to over 600,000 workers in 2013. And these increases have been driven by the ageing of the population as a whole, but also by increased participation of older workers in these age groups. But when we think about ageing, which was spoken about this morning in the keynote presentation, we need to think about more than just chronological age. So if you think about ageing as the biological, psychological, social and societal changes that take place, we have chronological age, which is related to ageing. Chronological age is also related to functional age, functional capacity, and we saw this morning in the keynote presentation that as we get older, our functional capacity does decrease at different rates throughout the life cycle. But there's also things which are important, such as societal age, societal perceptions of when people should be retiring, Minister Flynn was talking this morning about the scrapping of mandatory retirement in 2006, and that places different perceptions on when is the right time, or when is there a time for older workers or for people to retire. And organisational age. So with increased age comes increased task knowledge, also increased job tenure, and this also plays a role in terms of how ageing impacts labour market participation and risk of work injuries. So it's important to think about age not just as a number, as a chronological age, but also about all these other factors that go into what it means to be an older worker or a younger worker. The presentation I'll be giving today will primarily focus on the functional aspects of age, chronic conditions, because that was an interest of ours to try and understand, well, what is the relative contribution of different chronic conditions that increase with age on labour market participation. Because we know that certain chronic conditions are more common among older workers. So this is the Canadian labour market in 2011-2012 from the Canadian Community Health Survey, which are large surveys conducted by Statistics Canada. And we can see that conditions such as arthritis, hypertension, diabetes, heart disease, they have quite a difference in terms of workers, their prevalence in workers who are 50 or older versus those that are younger than 50 years of age. But other conditions such as mood disorders, migraines, to a lesser extent back problems, don't have the same disparities across age groups. And so this is a study from 2014 where we looked at, well, what's the relationship between age, different chronic conditions and reasons for leaving the labour market due to health reasons. So in Canada between 2000 and 2005, you can see that approximately 6% of Canadians reported in these surveys that they were unable to continue to participate in work due to their health. And you can see in the blue columns in the graph that there is a very steep age gradient going from less than 2% of workers who are 25 to 34 years of age to over 20% of workers who are 55 to 74 years of age. You can also see in the conditions that we examined, there were 7 in total: arthritis, hypertension, back problems, migraines, diabetes, heart disease and thyroid conditions. The people who had those conditions were more likely than the population on average, so the population being the red column, which is 6%, more likely to report not being able to work due to health reasons. And this was from a low of just under 15% for those with migraines to over 35% of those with heart disease. And we're also doing some work at the moment looking at the relationship between age and different chronic conditions with activity restrictions at work. So this is a question which asks people, are you currently limited in your the normal activities you can do at work, and how often? Sometimes, often or never. And again, we find just under 15%, around 13% of Canadians report that they have some level of activity restriction at work. And you can see that, again, that does increase with age, although not to the same extent as leaving the labour market. You can see there's actually a plateau there around 45 years of age, and workers who are 55 to 74 don't actually report any greater activity restrictions at work than those workers who are 45 to 54 years of age. And also the difference between the youngest and the oldest age group is also smaller. And the key conditions which are related to activity restrictions at work: arthritis, back problems, heart disease and mood disorders. Although, as I said, mood disorders doesn't increase prevalence with age, and so it's unlikely to explain the increased activity restrictions among older age groups. So what we can do when we have this data is, in regression models, we can run models which are with and without adjustment for chronic conditions. And all this basically does is it gives us a probability estimate. And then when we add chronic conditions in, what we can say is, if those things were equal among age groups, what would the increased probability be that older workers would not participate due to health reasons compared to younger workers who are a reference group? And so from this graph, these are odds ratios, so these are just likelihood estimates. You can see that before adjusting, older workers 55 to 74 years of age were about 9 times as likely to report not working due to health reasons. Workers 45, just under 4 times as likely. Workers 35, twice as likely. And where the red bar goes to is it tells you what is still remaining, which is still unexplained after adjusting for the different chronic conditions that I mentioned before. So if the prevalence of chronic conditions was equal across all age groups, would older workers still have an increased an increased likelihood of not or having to leave the labour market due to health reasons, and we'd find, they would still be just over 5 times as likely to have to leave the labour market due to health reasons. So chronic conditions are important, but they're not the full story in relation to understanding not being able to work due to health reasons. And then when we look at activity restrictions, we get a slightly different picture. So same way to explain the graph in terms of these are probability estimates, the blue being what we explain and the red being what we don't explain. Again, the key difference which you can notice here, which we showed in just the frequency tables, is that the relationship between age and activity restrictions at work is not that inverse gradient or that gradient that we tend to expect when it comes to age. We tend to expect that older workers have greater problems in participation in general, but this is not the case in terms of activity restrictions. You can see in terms of likelihood compared to the youngest age group, older workers without adjustment for chronic conditions are less likely to report activity restrictions at work compared to those who are 45 to 54 years of age. However, chronic conditions are an important factor. You can see by the size of the blue bar here in terms of understanding why older workers report more activity restrictions at work. And this is between 2003 and 2010. In relation to work injuries, workers' compensation agencies are dealing with an increased number of claims from older workers. This is the distribution of compensation claims in Ontario, lost time claims in 1991. You can see that the highest prevalence of claims was in the 25 to 34 year age group, which contributed just under 35% of all claims received and accepted by the WSIB in 1990. Move forward to 1996, you can see that now we're seeing a shift in the columns. We're moving a bit to the side. 2001, the greatest prevalence is in workers who are 35 to 44 years of age. And move forward to 2008, you can see that the highest prevalence is of workers who are 45 to 54 years of age. And these increases in numbers often lead people to believe that older workers, there's an increased risk of injury among older workers, but this is not the case. These increase in numbers is primarily or almost solely driven by the increased numbers of older workers in the labour market and has very little to do with changes in the rate of injury among older workers, which has remained remarkably stable. And the relationship between age and the risk of work injury does depend a lot on the type of injury. This is WorkSafe BC claims in British Columbia between 1997 and 2005-2006. Again, we've got of presenting odds ratios here, which are probability estimates. Our reference group here is workers who are 35 to 44 years of age. When we have a dot and a line above the 1, that means there's an increased risk of injury. When it's below 1, that means there's a decreased risk of injury. And the little lines there are 95% confidence limits. I don't know if those of you have spoken to researchers, but we get very nervous about ever making a declarative statement. So we want to be sure, we want to leave ourselves with a 95% chance that we're right. And that's what these lines indicate. And so you can see for things like bone trauma, so fractures, there is an increased risk of injury among men in British Columbia compared to workers who are 35 to 44 years of age. Open wounds and cuts, you can see almost the mirror opposite image, where younger workers are at increased risk of open wounds. And for muscle trauma, musculoskeletal conditions, it's actually an inverse U-shaped relationship. Older men are at decreased risk, as are younger men. In fact, the highest risk of injury for musculoskeletal conditions as a rate is among workers who are 35 to 44 years of age. For women, you get almost identically the same picture. Slightly lower risk of injuries for open wounds, slightly higher risk of injury among older workers for bone trauma. That's mainly due to osteoporosis and an increased risk of fracture. But again, for musculoskeletal conditions, you can again see it's an inverse U-shaped relationship. We do know that older age is associated with longer duration of wage replacement following an injury. This is a study we did which was published in 2014, looking at musculoskeletal conditions in British Columbia and the length of time people are away from work. What I've presented here on this graph is we've got blue and red here, red for women, blue for men, where the blue box and the grey box meet. That is the median. For those of you who are trying to think, what is a median? I know that's something to do with distributions. That's the midpoint of the distribution. You can see when it comes to days of injuries, our distribution is not a normal bell-shaped curve. It actually has a long tail, and that's why the size of the red boxes and the blue boxes is bigger than the size of the grey boxes. So at the median, we know there's a difference of about 8 days between age groups, between 15 to 24-year-olds and 55-year-old men, and 8 days between 15 to 24-year-old women, and actually 35 and 40 to 44-year-old women. Again, you can see here that the relationship between age and duration of wage replacement is actually not a simple relationship, and actually does differ quite a lot for men and women. Whereas men, as you increase in age, the duration of wage replacement is longer. For women, we don't see that relationship. It peaks among those who are 35 to 54 years of age and is actually lower among those who are 55 plus. And so what we were able to do in British Columbia is in British Columbia, workers' compensation data is linked to the equivalent of OHIP. And so we were able to look at physician billing records and hospitalisation records and to find people who had prevalent chronic conditions before their injury. So these are things that occurred in the 5 years leading up to their injury. And we could look at the distribution of these pre-existing chronic conditions among men and women and look at how much of a factor they contributed to duration of wage replacement following an injury. And again, you can see, similar to the graphs I showed before for the Canadian Community Health Survey, there are certain conditions such as osteoarthritis, which have quite a steep age gradient, hypertension. So these are osteoarthritis, rheumatoid arthritis, diabetes mellitus, which is DM, HPP is hypertension, coronary heart disease, hearing problems, depression and thyroid conditions. So you can see some conditions such as hypertension, diabetes, coronary heart disease and osteoarthritis do have quite a steep age gradient. Depression, as I said before, tends to peak in middle age group. This is men. Women, similar picture. Prevalence of depression is much higher, as is the prevalence of osteoarthritis. And interestingly, in more recent cohorts, the prevalence of hypertension, which used to be a disease we think about primarily among men, is actually now quite similar among women. So this is the distribution, and what we wanted to do is examine what is the relative contribution of these conditions to age differences, which I showed you before in duration of wage replacement. And so what we did is we did an analysis called path modelling. I won't bore you with the details, but what this allows us to say is, out of the age gradient, which is what I showed you before, so we're an increasing gradient among men, this sort of plateau, slightly declining gradient among women, if we think about that whole difference, what is the relative contribution of our chronic conditions? And you can see here again, by the size of the total column that is filled up, osteoarthritis and diabetes play a role. Other chronic conditions, all the other chronic conditions I mentioned, play a very, very small role, and most of the relationship is unexplained. It has nothing to do with pre-existing chronic conditions in terms of this analysis. So, to finish off, just answering the questions, the first 4 questions which I posed to you at the start. Yvonne will be answering the last 2. So the number of older workers in the labour market is increasing. Yes, that's true, both through ageing of the population and increased participation. Older workers leave the labour market or have restrictions at work because they have more chronic conditions. Yes, that's part of the reason. Importantly, it's different depending on the conditions. So while there's a steep age relationship between leaving the labour market, we don't see the same relationship between activity restrictions at work. This could be a healthy worker effect. This could involve that the relationship between age and these conditions is different, or the relationship between chronic conditions and each of these 2 outcomes is different. Older workers are at increased risk of injury. Well, there are no uniform declarative statements around age and risk of injury that are possible. The relationship between age and risk of injury does depend on the injury type, and it also depends on a lot of other factors such as the workplace context, how long a worker's been in the workplace, and so making declarative statements based on age is not really helpful. Chronic conditions are the main reason older workers take longer to return to work. Well, osteoarthritis and diabetes, they are important, but they explain a very, very small proportion of the age differences in return to work following a musculoskeletal condition. And what this work has taught us as a body is that the relationship between these conditions and each of these different outcomes does differ. So just to say osteoarthritis is bad, well, it might be bad in relation to leaving the labour market. It may not be as bad in relation to activity restrictions at work, and it may not be important at all in terms of return to work after a work injury. And so we need to start thinking about what is the relationship, why does the relationship between age and chronic conditions and each of these 3 outcomes differ? And that's where we'll be pursuing our research agenda in the future. So with that, I'd like to end and call up Ivan to give the second half of the presentation. Thank you.
So today I'll be presenting a study that's been funded by CHR. It's a systematic review on the topic of return to work and stay at work in older employees. When I was writing the proposal, they just announced that the retirement age was going to be raised to 67 years of age. It was on a Thursday. I was listening to the radio, so I thought, well, that's convenient. It makes it really clear that it's an important topic. So we've done a systematic review. Systematic reviews are large teams. So I'm not going to read all the names. I'd like to mention, the people that are here in the audience, Amin Yazdani, who's from University of Waterloo, and Emil Tompa. And I'd like to point out Judy Geary, who some of you might know as being retired from the WSAB. Well, she's still very active, and she's been an active member of our research team as a researcher, so not just as a stakeholder, and she's been a great asset to our team. We have a large stakeholder team involved as well that helped us to make it clear to the CHR that this is really an important topic and that people really want to hear the results of the study that we proposed. I'm not sure if anybody that's on this slide is actually in the audience, because most of the contacts that we had were over the phone. So if you're actually from an organization that's on this slide, please approach me after the presentation and we can meet. So I'll be discussing the common statements that we hear about older workers. So older workers need different types of interventions to help them stay at work or return to work after an injury. And the other statement is older workers with MSD conditions need different types of work interventions. So is that true? So some background. The Institute for Work and Health has done systematic reviews on return to work, and one of the reviews is about to be published, and Trevor King in the audience from the Institute for Work and Health will probably do a lot of KT on it. And we know that there's a study that's a systematic review that's been done in the UK by McDermott, who summarized the literature up to 2007. And they concluded that very few occupational health and safety interventions have addressed the health and workability of aging workers. We decided that we might actually be able to do a slightly better job than what they did. And that's and we're also expanding it. We're not just looking at interventions, but we're also looking at prognosis. So what are the determinants that make people stay at work, or older workers to stay at work or return to work after an injury? So this is the stakeholder engagement process that we use at the Institute for Work and Health. So in all these steps, we actually involve stakeholders. So stakeholders have helped us to develop the question. They helped us to come up with our literature search and the search terms that they wanted to see in our search strategy. We provided some publications, and they told us whether they were relevant to them or not. And in the end phase, at the evidence synthesis part, we're going to have feedback sessions where they actually provide us feedback, whether we make sense or whether they need some additional information on how we should actually communicate our message. For me personally, why I got somewhat intrigued by this field is that when I was doing my PhD in the Netherlands, we did a randomized controlled trial on the effectiveness of participatory ergonomics in workers that were away from work due to low back pain. And I was interested to see if that intervention was more effective in certain subgroups. So we decided to look at a number of subgroups, and it actually turned out that the intervention was more effective in people that were over 44 years old. So it's actually more effective in older workers. And that was, to me, quite surprising, because I think the notion is that older workers are much slower in getting back to work, so that we actually had an intervention that was more effective in older workers was a surprise. Of course, the question remains why. So that's future research. So this is a survival plot, where actually, so you only have to look at the end of the curve, where it actually says on the green line those workers that did get the intervention, and most of them actually got back to work within a year. where the blue line is the group of workers that didn't get the intervention, and there's actually a considerable proportion of people that are still away from work at the 1 year mark. So the research questions for the systematic review was what's the effectiveness of interventions aimed at return to work and stay at work. So we also want to look at determinants that are associated with return to work and or stay at work in aging workers. And we were interested whether different interventions were effective in different conditions, and in this case in MSDs. So I'm going to focus on the first question. So what's the effectiveness of interventions? And I'll try to answer the question whether different interventions are more effective in MSD, so whether you need different interventions if you're dealing with workers with musculoskeletal disorders. So we were interested in return to work and stay at work. Return to work might be familiar to you, so it's time on sick leave or disability benefits. We weren't interested in studies that reported that they measured the intention to return to work. So people say, oh, I'm ready to go. We wanted to have clear return to work and preferably in the old job. And we weren't interested in workability either. So do you think you will be able to go back to work? We wanted to have a firm endpoint. And in that sense, we also differ from the study that was done in the UK by McDermott. So what we mean by stay at work is that we are looking at studies that look at early retirement. So that can be positive and negative. We look at studies that report on permanent disability pension. Some of the Finnish studies actually use the phrase permanent disability pension. And we are also looking at the number of days at work that somebody that's still at work actually has to take off because of a condition or age. So we're not looking at intention to retire. There's a lot of studies out there that actually ask, so do you think you'll make it to 65? And will you be able to work until 65? So we're looking at quite firm endpoints. You might say, well, that's a waste. Well, there's a reason why. So we looked at all interventions, so we're not restricting ourselves to workplace-based intervention or healthcare-based intervention or policy-based interventions. We do look at studies that actually have some sort of a control group, so an intervention group and a control group, so we can actually give an effect estimate. So our main objective was we want to look at those baby boomers that are now retiring. So we had the people that were born between 1946 and 1964 in mind. So in the end, we decided to mainly look at studies that included people that were 50 years and over. But we were a little bit flexible in that aspect because, as Peter presented about the slide with chronological age, biological age, in some professions, if you're 45 years old and you're a construction worker, you're probably considered to be older than when you have a slightly less physically demanding job. So we included those studies on physically demanding professions that actually included slightly younger workers. Some preliminary results. We found 14 intervention studies that all had some sort of a control group. It could be a full-blown randomized controlled trial where people were allocated at random to the intervention or the control group or a usual care group. One of them was from Canada, and it's actually a French language study from Quebec, 5 from the USA, 1 from the Netherlands, and there's 2 international studies that we probably should go into more depth at a later stage, because that's actually a study where they looked at multiple jurisdictions, so they could actually look at differences between countries. So we included people from a cardiac population, from a general working population, people with an musculoskeletal disorder, and some studies with rheumatoid arthritis. So 4 from a cardiac population, so after a myocardial infarction and then returning to work or staying at work. I think this is 5. So quite a few from a general working population where they did an intervention and people that were still at work, functioning relatively normal. A few in MSK and a few in rheumatoid arthritis. So these are the kind of interventions that we found in the literature. So we classified it into work modification interventions, healthcare interventions, and what we call service coordination interventions. So in the work modification interventions, the workplace was assessed, people were accommodated, there was a job task analysis, there were modified duties presented and offered, modified working hours, and participatory ergonomics is one of those interventions that fits under the work modification category. Then in healthcare, there was graded activity, work hardening, exercise, but also specific types of surgery, like in whether one kind of heart operation was different from another. Medication, so whether one medication form was better than the other. Workplace wellness, psychosocial care, and physiotherapy. And service coordination was more about having a return to work plan, case management, getting all the stakeholders lined up. And early intervention was also one of the interventions mentioned there. And then there was a group that actually combined those interventions. Quite a few actually did a combination of all, more of a shotgun approach, but they did multiple interventions. There was actually only one that only did a work modification. There were 4 that did a combination of different interventions. Some of them did medication. One of them was on flu vaccination in older workers, and 3 on exercise. So 4 looked at return to work in older workers. 9 looked at stay at work, so early retirement. I think that's the one that we were, in principle, mostly interested in. And one study was quite interesting, looked at both. So they had people that went back to work, and then they followed them up longer to see if they actually could stay at work after getting back. So what's the effectiveness of interventions aimed at return to work and or stay at work in aging workers? So these are, I've never presented these results anywhere, so you're special. So the effectiveness, so 3 out of 14 studies reported no effect. And these were actually quite good studies, so they had a quality score. We have a quality score where people can range from 0 to 10, and they had a quality score on average of 6.7, so that's actually a pretty good study. So it's not because they are crappy studies that they find no effect, it's probably more the opposite case. So one study reported that they provided information to the patient and the family doctor. One looked at yoga and workout. I think this is actually a Dutch study, so I think there's a mistake. I think there's actually 2 Dutch studies in this overview. And one of them looked at the specific type of drugs. And I wasn't, they fit all the inclusion criteria, but I'm not really super interested in that from my point of view. So 11 studies found a positive effect, so that's quite a few. That normally you find more studies that don't find an effect but still report on it. So 3 were in cardiac populations. So one study reported on participatory ergonomics and exercise. That's the Quebec study. One of them had work hardening and exercise on return to work, and one looked at minimally invasive surgery. So if it was minimally invasive, people got back to work faster and actually stayed at work longer. The study quality is 4.2 out of 10. So that means that I think there's only 1 RCT there's no RCTs in here. So the quality is slightly lower. So there were 4 in general working population, so that's the kind of population that you might have in a company. One looked at Tai Chi and found a positive effect. It was a really small randomized control trial. One looked at influenza vaccine in older workers. One looked at modified duties. And these studies were slightly better, 5.5 out of 10, so it's getting there. 2 were on musculoskeletal disorders. Again, the participatory ergonomics, it was my study, so the study that we mentioned in the first part. And another study looked at whether getting someone to help to do one's job made a difference, and it actually did. And then there were two in rheumatoid arthritis, one on education, counseling, and accommodation, and one on specific medications. So again, one type of drugs versus the other. And these were actually pretty good studies with a score of 7.8 out of 10. So what about those common statements? Older workers need different types of interventions, and older workers with MSDs need different types of work interventions. Well, everything that we saw in those publications, and it's a part where we need to look into a little bit more in depth, it very much reminded us of the 7 principles for successful return to work that the Institute has published based on an earlier systematic review on return to work. So all of those factors seem to show up, first of all, in return to work in older workers. So that doesn't make that much, that's not really that much of a surprise. But the same principles also seem to apply in keeping people at work. So keeping them at work until the moment that they can safely retire. The same goes for musculoskeletal disorders. It seems that similar interventions are applied across populations and outcomes and seem similarly effective. So it doesn't seem like, of course, you have to always have a bit of tailoring, but the general principles from all these interventions across conditions are actually quite similar, involving the worker to come up with a solution. The exercise part is quite similar. So the principles seem to be very similar, and of course they're always modeled to the specific case. So recommendations for practice. So similar interventions seem effective. The 7 principles hold true in return to work in older workers and in stay at work. So I think the only difference between some of the studies is that return to work is most often reactive. So somebody goes on benefits and suddenly everything needs to get in place. Where interventions in stay at work in the studies that we looked at is very proactive. So there's a little bit of time to actually start up the intervention, to make an inventory of who actually needs the intervention, and then the next step is actually to intervene. So I come from return to work research, so to me it seems with all the hectic stuff going on when you do a return to work intervention, this seems you have much more time to actually do a stay at work intervention, it seems to me. So the next steps will be to review the determinants of return to work and stay at work in older workers. Because we seem to agree on what we should do at this moment, but maybe that a review of those determinants actually provides us with some determinants that are not intervened on yet. So it might actually mean that we could improve some of those interventions. So there's consensus, but we might actually be able to add some evidence on what determinants could be targeted in newer interventions. And we could also identify those that are at risk, and you might want to focus your interventions on those that are at highest risk to leave the labor force early. And of course, we would like to know whether these interventions are equally effective in Canada. I'm a scientist, so I always end my presentations with further research is needed. So questions? This is just a way to keep up with the evidence-based practices from the Institute for Work and Health. We have the whole social media going on, and you can always send Trevor an email. No, you can also send me an email, but there's a lot of different ways that we try to inform stakeholders. That's it? Yeah. Okay, that's it.
We have time for a few questions, both for Ivan and for Peter. When you ask a question, if you could please give your name and where you come from.
Hello, Susan Wood from York Region EMS. You had outlined that there was 14 research or surveys going on, or the research, and there was only 12 listed. So I was wondering.
I'll have to check.
They didn't count?
So I already saw that one that I think there's 2 from the Netherlands. So we'll have to do the count. I was a bit so Kim Cullen made some of the slides, and I was confused by 1 or 2 of them as well. So it could actually be that she mentioned the quality score, and that's why it doesn't add up. But no, more. We have to look into it. But it's 14 studies. So there's actually a German study and there's a French language study. Most of them are actually in the English language.
Thank you. Bob Gautreau, City of Toronto. Just to be clear, the quality score is a measure of the quality.
So that's us as researchers judging our peers.
Right.
And more or less, we have a list, a quality assessment list, where we rate each study on certain scientific criteria. So we can somewhat tell people, well, this is a really good study. So it's not because they have some chance finding, it's because it's a really good study. And in some cases, the study is just of a lesser quality. We have issues with the way they designed the study or with the way that they actually did their analysis. So we tend to rate that study a little bit lower.
But it's not
so
a comment
in the
on
end,
the results. Yeah.
Huh?
But it's not a comment on the results. It's just the quality of
No,
the study itself.
but we do say that if the quality is really low, and that's not really the case in these studies, then you should be careful with how to interpret the results.
Are there any other questions? Cool. Great. So we'll another round of applause here while we get
Okay,
set up
thank
for the
you.
next.